Hello, my dear residents. I'm Dr. Arjun, a consultant in charge of earlier super specialty hospital from Chennai. So today we'll talk about oncologic emergencies. In that, the first topic is tumor lysis syndrome. So what is tumor lysis syndrome? So it is a combination of electrolytes rearrangement and acute kidney injury occurring secondary to massive cell lysis that can be triggered by treatment. See, the combination of electrolyte rearrangement and acute kidney injury occurring secondary to cancer and sometimes secondary to massive cell lysis, which is triggered within the first several days of cancer treatment. So that treatment is often cytotoxic chemotherapy, but tumor lysis syndrome can be triggered by monoclonal antibodies, steroids, or sometimes radiation therapy. So the spontaneous tumor lysis syndrome in the absence of treatment can also occur, but it is less common. Coming to the clinical presentation, so the typical features, see the lab abnormalities are present prior to the symptoms like hyperkalemia, hyperphosphatemia, hypocalcemia, hyperuricemia, and acute kidney injury. And if unrecognized and untreated, tumor lysis syndrome will lead to nausea, vomiting, lethargy, seizures, renal failure, and potentially fatal arrhythmias. See, the pathogenesis, it is a very complex subset of dearrangements, and mechanism are responsible for majority life-threatening manifestation. So what do you see in the flowchart? It all starts with a massive lysis of tumor cells. When this happens, all the intracellular content spill out into extracellular space. So the three components is a problem. The first one is potassium, which has higher intracellular than extracellular concentration. Then hyperkalemia can lead to arrhythmias. The second problem is the nucleic acid of DNA and RNA are metabolized via several steps into the uric acid, and that uric acid is poorly soluble in water, particularly in the acidic environment of renal tubules. So the collecting system where the urate can be deposited. And the third problem is the phosphate. It's also released, and these complex with extracellular calcium, resulting in hypocalcemia and calcium phosphate deposition in the renal tubules. So therefore, the uric acid and the calcium phosphate act together can cause acute kidney injury. Then it can lead to hyperkalemia and hypocalcemia that places the patient at seizures. So coming to the malignancies at increased risk of TLS, the first one is acute lymphoblastic leukemia. The second one is acute myeloid leukemia, where in which the white cell counts exceeds 25,000 per microliter. And the third one is a non-Hodgkin lymphoma, particularly the Burkitt lymphoma. So the other risk factors are the large tumor burden, increased WBC, the pre-treatment which increase the uric acid, the pre-treatment LDH which exceeds more than 2 times of upper limit normal, chronic kidney disease, volume depletion, and some specific chemotherapeutics. So coming to the diagnosis, see there is no diagnostic criteria, so we can divide into two. One is the laboratory TLS, that is the patient will be asymptomatic, and the second one is clinical TLS, where the patient will be having symptoms. See, the development of treatment-induced TLS is rarely a diagnostic dilemma, but spontaneous TLS can be mistaken for acute kidney injury from dehydration and ATN if a serum uric acid is not measured. So coming to the treatment part, see the best treatment for TLS is prevention. And for the patient at a moderate high risk, see the first one is aggressive IV hydration like 150 to 200 ml per hour for average sized adult, and hypouricemic agent. If moderate risk and baseline uric acid is normal, then we can use allopurinol. And for other moderate high risk patient, we can go with raspuricase. And if the patient is contraindicated to allopurinol and raspuricase, then the choice is febuxostat. Coming to the monitoring, for moderate or low risk patient, we have to check the lab for every 8 to 12 hours. And for high risk patient, check the lab for 6 to 8 hours. Close monitoring of urine output in all the patients. If the TLS has already developed, then we have to start with the aggressive IV fluids, initiate raspuricase, aggressive management of increased potassium and increased phosphate, non-aggressive management of hypocalcemia so that to prevent precipitation of calcium phosphate, and when in case we have to transfer the patient to ICU, and finally renal replacement therapy if the patient is needed. And without any further delay, residents will go to the next topic, that is hyperleukocytosis. So this is one of the true hematologic emergencies we see in oncology and emergency medicine, and it is not just a number, and it is a kind of a life-threatening, so we have to act very quickly. So basically the definition is the white blood cells count which is above 1 lakh, So we mostly see this in acute leukemias, especially in AML, that is acute myeloid leukemia. The important point is not just for the lab abnormality, so we should think of emergency condition. So why it is dangerous? So this is because the blood becoming thick and sluggish because of all these blast cells, and these cells don't flow properly in small vessels, so they start blocking the microcirculation. So that's why this leads to the organ ischemia and early deterioration. See, under the pathophysiology, the key issue is the blast. They are large, rigid compared to the normal WBC because they can't deform well. So they get stuck in small vessels. So this is how they cause a low oxygen delivery, endothelial damage, and even micro thrombi formation. So coming to the leukostasis syndrome, so this is a clinical syndrome we are very worried about. That is, lung and brain are the most commonly affected. So in lungs, the patient may present with a severe pneumonia or ARDS with hypoxia, and in the brain, they can come with confusion or even stroke-like symptoms. Yeah, apparently the clinical features in this, a patient may look very sick. Most commonly, they have a breathing difficulty. Some will be like confused and a drowsy state. Occasionally, we see the visual complaints or bleeding tendencies, and especially if there is associated DIC in AML. Coming to the investigation, of course, CBC will show very high white cell counts, and periphery smear usually confirms the blast, and ABG may show the hypoxia if lungs are involved, and we can also check the coagulation profile if DIC can occur. And importantly, we should also send a tumor lysis lab at the same time. So the emergency management should start immediately, even before the final diagnosis confirmation. So the first is stabilization, like oxygen and supportive care, and then the hydration, but carefully if there is any respiratory distress. And then the hydroxyurea is the first drug we use for cyto reduction. And in some severe cases, we can consider leukophoresis if available. And we must prevent the tumor lysis syndrome. So here the question is when to escalate. See, if a WBC is above 1 lakh and the patient is symptomatic, especially with the respiratory or neurological signs, we should treat this as ICU level care. So any suspicion of leukostasis or rapid deterioration should trigger an immediate hematology or ICU involvement. So the final key takeaways for all the residents is that hyperleukocytosis is not just a lab finding, it is a true oncology emergency. So the early recognition is a very important step, and the treatment should not wait for any confirmation because this delay can lead to increased mortality. So rapid cytoreduction is life-saving. So without any further delay, we'll go to the final topic, that is hyperleukocytosis. So it is a condition characterized by increased level of leukocytes in blood. Although it typically occurs when you are sick and also caused by several other factors. We'll talk about the symptoms now. The fever, bleeding, feeling weak, tired or sick, feeling dizzy, fainting or sweaty. The patient might have pain or tingling in your arms, legs or an abdomen. We'll talk about the causes. So the main causes of leukocytes are infection, inflammation and tissue damage. And immune reactions such as during asthma or allergic attack. A bone marrow problem such as leukemia or thrombocytopenia. The medicine which is used to treat inflammation, mental health disorder, cancer or breathing problems. So coming to the diagnosis, 3 different types of tests are commonly used to help determine why you may have increased level of white blood cells. The first one is CBC with a differential count test. This test uses a machine to determine the percentage of each specific types of WBC. And third one is a peripheral blood smear. So when you have neutrophilia or lymphocytosis, your doctor may perform these tests, which can look at the form and the maturity of all blood cells. This test may not confirm the type of leukocytosis, and if there are immature WBC, it may lead to bone marrow biopsy. This test involves smearing thin layer of blood into a glass slide and using a microscope to view the cells. So the bone marrow biopsy, this test is used to differentiate leukemia from benign causes. It involves taking sample of your bone marrow, the tissue that produces the WBC, from the middle of the bone using needle. This helps determine if there is any abnormal cells or an issue with production of WBC in the bone marrow. So coming to the treatment part, the treatment for leukocytosis can vary depending on the specific causes, like antihistamines, the use of inhaler for asthma attack, use of antibiotics for bacterial infection, and cancer treatment like chemotherapy, radiotherapy, stem cell transfer, and medications to treat stress or anxiety. So coming to the precaution, so there are several ways to prevent leukocytosis. That is maintaining a healthy and active lifestyle, maintain proper hygiene and hand washing to reduce the stress levels, and performing a treatment for anxiety or mental health issues, and avoiding to potential allergens, and to quit smoking, and finally taking medication for any health condition as directed by your doctors. And thank you for listening, and I thank for the semi directors for giving this opportunity, and also very big best wishes and good luck to all the final year residents. So all the very best, and do read about the tumor lysis syndrome, hyperleukocytosis, and leukostasis. Thank you.